Olivier Farmer. I'm a psychiatrist. We have a program at a couple of shelters. We got some funding from the government post Chez Soi, which fell to pieces in Montreal and wasn't funded for lots of political reasons. But anyway, we decided to do something else with the money. I have, which I won't talk about, it won't be too long, but I have two questions. I have one issue with the science, establishing housing first as an evidence-based. One of the problems is comparing a program which was putting $1 million, almost $2 million to treatment as usual, which is the equivalent of putting 10 people to dig a hole on this side and 2 people to dig a hole on this side. And then this hole is bigger, and then you're saying, well, maybe it's the digging technique, or maybe it's the shovel is better on this side, rather than just having 8 more people on this side than on this side. So what I'm saying is that really the only thing you demonstrate is by putting specific resources to deal with housing and health and supports for homeless. It works. Putting money and resources into works. Is it the specific aspects of the model? Well, you would have had to put 10 people on this side and 10 people on this side. So for example, in ACT, the traditional ACT, they started to compare ACTs that have higher fidelity, and then they would be able to compare the efficacy, which I don't think in Housing First we've been able to do yet. So I have strong reservations about model aspects being really determinants. I don't think the science is strong for that, even though it has worked, and I was part of the at-home consortium here, and I even worked in the team a little bit, and I believe it is a good but expensive proposition. The other thing about the cost-saving argument, so obviously, that this is about advocacy and the discourse with policy people. It's really difficult not to go into that. So one of the ways to avoid what you were saying is to say that, okay, all this extra money that's spent on this side is wasted money. This is police intervention that leads to nothing useful for the client. This is, many visits at the emergency room that lead to no proper treatment. This is a visit to the prison, which is obviously completely useless for the person. Whereas this extra cost is actually there to help the person and actually does help the person. So this idea, people also don't like to waste good money and people. The other thing, the one last thing about the cost saving is that, well, if we have a model that, or let's say a way of doing things, model is a charge word, but a way of doing things that really works better, well, won't the resources on the treatment as usual side start migrating towards the more effective model? So we've been working with, for example, the shelter system, and they have displaced resources to work with us. We are working to displace resources that work maybe a little less efficiently than what we're doing right now, and towards us, and starting to get the efficiencies that we get. So my point is that having a very efficient system can also modify the environment in a way that could lead to more better spending the money for the homeless.
So maybe I can just address 2 of the questions. So thank you for those really insightful comments. With respect to the first question, I think you're correct, actually, which is that housing first in the study was tested against whatever existed in the community, usual care. And so therefore, the results of the study should not be interpreted as demonstrating the superiority of housing first to every other possible alternative intervention. I think that this gets into I apply my lens as a physician, which is that this is kind of like the realm of comparative effectiveness in medicine. So you may have a condition that, let's say a cancer, that's treated with a treatment regimen. And first of all, we have to know that that regimen works. But then once it works, and you have more than one choice, if you know that something works, or you have a couple of regimens that work, you'd like to know which one works better. And that comparative effectiveness is important to determine. But also very hard to do and very expensive to do those studies. So I would acknowledge that, yes, the reason that Housing First is, I think is I think it is evidence-based, but I would not make the claim that the evidence shows that it's superior to a different model. It's simply superior to what we're currently doing in our fragmented, disorganized approach. The second point I think that you make is an excellent one, which is that we want to get away from making the argument being around just simply cost savings, and I think the idea that waste, everyone abhors waste, and the idea that we're avoiding wasting resources is an excellent one.
I have two questions actually. One is, I did notice that you have a tremendous, in all your measures, regression to the mean effect. How do you explain it, and what is it? You know, and independently, that the control group and the randomization and all that, but why do you have this regression to the mean effect? And my second question is, did you check? There are outcomes and individual outcomes. Homelessness is also a societal outcome. And so if people are in their house, they're no longer in the street, and there's this idea of order and disorder. So were they replaced in the street, or is there a certain quota that regulates itself in the streets? I mean, those people who weren't in the street, were they replaced? How did it work at the societal level?
So those are, I'll address both questions. The first one about regression to the mean, as you saw in all the slides that showed results for Housing First and the control group, the control group improved dramatically or significantly compared to baseline. And we have had extensive discussions about why was that the case. I think that I think the main reason is that we recruited people across all sites. We tried to recruit people who were perceived of as being the hardest to serve, those who were in most need, those who were in really bad situations or difficult situations. And when you recruit people in those situations, in general, things will get better just because there's a floor effect. You've essentially hit rock bottom and the only place to go is up. That essentially is the popular saying that essentially describes what I think is partly what we were seeing. There were some in our group who believed that simply participating in the research study had a beneficial effect. That having a thoughtful, caring research assistant meet with that person every 3 months and talk to them had some beneficial effect. I don't doubt that it did, but I don't think that, I personally am skeptical that it accounts for that degree of improvement. The third explanation, and I think this is probably part of it, is that the control group was not no care, it was usual care. And as we all know, there is a basket of services and help available in the community completely outside of our study. And those services, I think, work. They help people. So it's not to say that give people nothing and they still get better. What it means is that giving people what we're currently giving them does have, I think, some beneficial effect. I think probably the first and the third explanations are the main explanations. And I would just add that it's the reason that we should always be really skeptical of studies that don't have a control group and show a significant improvement, because you may just be seeing regression to the mean. In terms of your second question, which is the quick answer is we didn't look at that. I think you're asking, so what happens if you take 200 people and you end their homelessness? Does that make a noticeable dent in the city and in the services that we need to provide? I can only speak from personal experience in Toronto, which is that no one has come to me and said, gosh, since you did the at-home study, we've noticed that there are just so many fewer chronically homeless people that we have to try to help these days. So I think that it just illustrates the fact that, we are like fishing people out of the river, but people are falling in. I don't think the study was at a scale to make a noticeable dent in the overall population. I think we would have to actually scale it up significantly, which actually I don't think has happened to the yet.
Est-ce que vous pouvez vous présenter avant de poser la question? Oui, Lucie Lemieux, médecin santé publique. I'm wondering if you've looked at how these people housed in these scattered housing, I forget the word you used, how were they integrated in the community that they found themselves in terms of the other people housed in the same areas or the same buildings?
So we have looked at that, and we continue in Toronto to follow these individuals for up to 5 years. The most interesting thing, I think, is that qualitatively speaking, because there was a qualitative component to the study, there was a lot of issues around a feeling of loneliness in moving into scattered site housing, and I think that's the biggest, one of the challenges that doesn't show up in the quantitative data, but does show up when you talk to people. That the sense that people felt somewhat alone and isolated in their units. And I think that's a real issue. I think that in terms of community integration, we did not see dramatic improvements in the quantitative scales. But I guess those are probably a blunt instrument to assess. The hope is, of course, that over time, that community integration will increase, but we don't know that for sure.
Yeah, James McGregor. I'm just trying to grapple with this issue of housing first on the cheap and fidelity to the model and the limits. And I'm wondering, the federal government has redirected a large portion of its homelessness money to housing first. Is anybody concerned about the quantity and the quality of the resources that are being applied to it and whether there's fidelity to the model?
Yes. So the federal government, it was the conservative government at the time, as a result, partly, a significant part due to the results of the at-home chez soi study, refunded its homelessness initiative. So I guess that they didn't cut it, which was actually what people's fear was at the time, but they didn't increase its funding. And I don't believe its funding has been increased by the current government either. And so it was simply redirected to, and people were told, now we need to use this money for housing first approaches. So there have been a lot of concerns in various communities that, first of all, this takes money away from other services that are not housing first services. And by no means was the study meant to say that all other services should be defunded. That was not the message of the study. And secondly, I know for a fact that in a number of jurisdictions, people are saying, well, okay, you can do this, but you don't need, this is all the money we have, so you're going to have to do it with a lower budget. And I think that what typically suffers is the quality of case management. Well, what suffers is the rent subsidy. It becomes very, very small or non-existent, and people end up getting housed in very low quality, and that's a euphemism for terrible housing. And also, it results in very high caseloads for the support teams. So rather, we had a 15-to-1 ratio of clients to case managers. If you don't have enough funding, then what happens is you have one person trying to juggle 20, 25 people, and that level of support may not be adequate. So yes, these concerns exist. So I think that we have to be very on guard for that. And the other thing is that it can't. This is not a model that can be applied with fidelity to everyone because of the cost. I guess I don't say it couldn't be. It probably shouldn't be. It should really be reserved for people who are chronically homeless.
Hi, my name is Anne Fera, working for the RAPSIM, which is an umbrella organization in Montreal defending the rights of homeless people. I just wanted to comment on what you said about the risk of focusing only on housing first, especially when we speak about policymakers. You just said that, in fact, HPS, the homelessness partnering strategy, has been shifted from a global orientation towards housing first. And we are currently living with the consequences on the ground, because in Montreal, 65% of the funds now should be dedicated to the housing first approach only, which means that there are many different services that are being cut. I mean food services, street work, day centers. And what you said before is that, you know, homelessness is really diverse. Housing first is perhaps a good model for chronic homelessness, but we need also to target other people who are experiencing different types of homelessness. So I think that we really need to advocate for a more comprehensive strategy towards homelessness. And this is what we have indeed in Quebec. We have a national policy on homelessness that was adopted 2 years ago. And I'm quite happy that you raised a kind of more balanced view of housing first in your presentation, because if we want to put an end to homelessness, we need to address the diversity of the cases, and we need to have a diversity of answers. So thank you.
Thank you for your comment. I think that your both questions are alluding to a really important problem, which is that it's the idea of there's only so much money, it's a fixed envelope, it cannot expand, therefore we have to take from one to give to the other, because it's a zero-sum game. And I think that mentality is actually dangerous, because essentially it says, we can't spend any more, and you have to just accept that for a fact. And therefore, once you accept that for a fact, then yes, it becomes a question of robbing Peter to pay Paul. But the problem is that that's not true. But sometimes housing first comes up in discussions where people say, well, we shouldn't be doing this, we should be doing housing first. It's not meant to be an either-or proposition. Just as, I don't think anyone says, well, we either have to choose between healthcare or schools. So shall we take care of sick people or educate our children? We can't do both. I think we recognize the fallacy of that argument when we talk about other aspects of social services. I think we should reject it when it comes to addressing the needs of those who are homeless and marginalized as well.
We've been cutting both for the last 2 years.
Well, that's because taxes have to be reduced.
Est-ce qu'il y a une autre question? Une au fond, puis tu vas donner la parole.
My name is Pierre Gaudreau. I'm a coordinateur du réseau d'aide aux personnes seules itinérant Montréal. I just want to add one point, one good news we've had from the first Trudeau budget. There is new money for the fight against homelessness. Not enough, but then again, the government has announced that for the 2 years that started April 1st, the budget of its homelessness program has been increased, so 50% for both years. So that's a good news. As we all said today, there is a need for action on many levels, chronic homelessness, but also others. I just want to make one point on the question of the success of the housing first approach on the figures you showed. That shows clearly that people get out of homelessness real fast when they have the support of housing first approach, because it's an immediate response to homelessness to offer housing and support. In Quebec, also in Canada, we've had also other responses, social housing with supportive housing, which is not an immediate solution. It takes time to build social housing projects. It takes budget. Then again, we're coming back to the issue of funding, of the issue of competition between funding, between solutions. I want to come back to you on the question as a searcher, as a doctor, of the impact you see of the way housing first is used. I've been an activist on social housing, on the right for homeless people since many years, and I see a very bad impact of how the model is used, not a bad impact of the model. For example, there has been a countdown in Montreal of the homelessness people, and in the second report of the countdown, there was some quality measures. Where did the people came? And for more than 50%, the people went through the yacht protection system. This doesn't mean that the job is not done, but it means a lot of people did have a rough time during the time they were young. So that means the importance of acting on prevention. Then again, the reports comes out, our mayor, Denis Coderre, and Valérie is here, member of the executive committee responsible on the issue of homelessness. I salute her and the administration. But then again, Mayor Denis Coderre said, we will act on chronic homelessness. The reaction of a report that says we have a problem, people on the streets are coming from the yacht protection system, more than 50% of them. The response of the mayor is to say we have people on the street and we agree we have to address that situation. But then again, if we work only with these people, as you said, in Toronto and in Montreal, even though the success of the at-home project, we have seen an increase of the people in the shelter in Montreal during these years. So don't you see there is a change? Do you think there is a change to address in the way the housing first approach is used in the movement in Canada as a way to end homelessness?
Well, I mean, I think I made clear, there's certainly potential for the model to be misapplied or misinterpreted. I think fundamentally it's a good approach, but as I mentioned, when you have a hammer, if you think everything is a nail, that's going to be a problem. And I think that we need to be open to a wide variety of solutions. And I think in particular for youth, that really requires a different level and a different kind of investment. I think to say that something that works really well for a 50-year-old man or woman with severe mental illness is the same approach that we're going to apply to a 18-year-old who's coming out of the child welfare system. I think that obviously doesn't make sense. So I think we have to be open to looking at what works for different populations. I think we do need to have good evidence for the approaches that we do use.
Yeah, a question just about this scattered housing versus grouped housing. I come from a background of social housing, and in the early 2000s I managed the City of Montreal's 5,000 social housing units program, and we built over 700 units for homeless people and people at risk. And for the couple of years following, the emergency winter shelters remained closed. We didn't need them. So there was an impact, and it was possible to get an impact, and this wasn't housing, but this is housing in the straight sense. It seems to me that one of the things you didn't mention as a disadvantage of the social housing, or the advantage of the scattered housing, is that not everybody is going to be permanently in need of the services they can get in a particular group home. And if they don't need them, then they're confronted with the issue, do I have to move out because I don't need the services anymore? So it isn't permanent housing, or not. So I think the group home solution is obviously a better one for people who have long-term disabilities of various kinds, or needs anyway.
Yeah, thank you for the comment. I think it's a very important one, that the Housing First model, because the services are portable, it can be they can be tailored, they can follow the person, they're not dependent on where they live. I think that it's an important advantage of the model. I think that your point about the fact that the truth, though, is that you're right that some people who don't succeed in scattered site or independent units do end up moving into supportive housing, and then they succeed. So it's, again, remember, it was not 100% that succeeded with the scattered site model. Some of those individuals ended up failing in a couple of apartments and then moving into supportive housing, and then it worked for them. So I think that, again, it's usually not people's first choice personally for themselves, but it sometimes is what ends up working best for them.
One of the things about housing first is, when do you stop being homeless? So, you are the homeless, and then you are the homeless with a home, because you have specific homeless services, and there is no end, there is no programmed end to it. So it's like we have people who have a permanent need for this degree of supports. They're often packaged, right? So you have the supported housing, and you have the supports, the team, and one goes with the other, and decoupling them is not necessarily that easy. At least that's how I've seen it. So there's a bit of a competing model that hasn't had as much research, which is the critical time intervention, which is that you do like a bolus, right, of interventions for a certain amount of time, and then they become no longer homeless, which means that they no longer need specific specialized services for the homeless, which is actually the track that we've had here, so that they move towards housing, which has the potential to be permanent and independent completely from the specialized housing services, and then they're referred into regular services, which has appeared to be more pragmatic in the context of Montreal. Now, you were talking about how the housing first being a pragmatic model, so it was developed mostly in New York. So I was a fellow in New York for a year at Columbia, and I can understand how it was pragmatic in New York. You could not have an apartment if you didn't have a very significant voucher for paying 25% of the revenue, because the rents are thousands of dollars a month. And then also, it is such a huge system that referring and having a proper team for the person coupled with... So housing first became the self-contained model, right? You do everything in-house. You do the housing, you do the supports, you do the medicine, all together, with no connection with anybody else necessarily. Forever. Not necessarily forever, but there is no programmed end. So that's very expensive long-term, because your choice is to sort of just build more and more housing first programs until you've covered everybody. So I don't know, has that been something that you have been thinking about with the research people?
Yeah, we've solved that problem. No, so you've raised an important issue. I think that the hope within the housing first model is that some people will achieve some level of recovery. They will need over time less services, and in some cases will no longer need services at some point, some of them. But what we found is that the need for the rent subsidy kind of becomes an ongoing issue, because people, essentially it's true at least in my experience in Toronto, you can't find a decent place to live on the income you have from disability. It's just not possible. So that becomes the ongoing challenge. I think that the critical time intervention is actually a model that I think is very evidence-based as well, and there's been significant success. It's been applied primarily to people moving out of shelters and into housing. I think that what's not entirely clear to me is that when the model was applied, what allowed those people to move into housing. I mean, it was done in New York City. I don't know if those people got rent supplements outside of the critical time intervention program, but in a way, they're still quote unquote dependent on the red supplement.
I actually have a quick question, maybe then the last one here and then the next one. Regarding your second point in your summary, dealing with the need of policies, do you plan, or what is your plans? Do you have plans to reach out to do something on that, or it's just are you going to send recommendations?
So it's a great question. So what I've discovered is that as a researcher based with a kind of a background in medicine, what I found is that it's incredibly hard to do research on policy. There are policy researchers, but it's very different from the kind of research that we do. And what I find actually is that rather than doing research in that area, I think what we need to do is to be advocates in that area based on our scientific, I think, credibility and expertise. Because I think we're never going to have a randomized controlled trial of whether providing an increased level of support for increased investment in affordable housing makes our society a better place and people healthier. We're never going to do that study. I think that we might have studies of a particular intervention versus another, but policy by its nature just happens. And I think we have to really be voices and advocates for that based on our understanding of the situation rather than requiring that we do another research study on it.
Thanks. And maybe the last question up there.
Sure. I'll try and be quick. I was wondering, there's a small portion of your population that did not stabilize in housing first. Can you tell us if you did a sub-analysis as to their differences with regard to those that did stabilize?
Yeah, so it hasn't been published, but interestingly, there were no clear predictors of who was going to do badly. So the bottom line is that it's very hard to know who's going to fail, quote unquote, this approach. So I think that it's reasonable to say that we should, if we have the ability to give people a chance, we should just give them a chance rather than saying, oh no, it's not going to work for you. So that's kind of the bottom line. I actually, the way the study was done by a large team of people, there were different parts of the data are being studied by different people, and I'm not part of the study group that's supposed to look at that. I should find out where it's at though. It's a great question. We've asked this question, and like I said, there's really not a clear predictor of who's going to do well. I mean, you might imagine that it's going to be something like severe substance use or severe psychosis, but actually not.
Honestly, I'm not surprised.
Well, thanks a lot.
Thank you.
Merci beaucoup. Merci pour la